formal presentation, and part of it's because it's being recorded. They put it on the website. And there's a lot of good talks. So my name is Livia. I've been doing this for a while. I became involved because Michael Goldberg was undiagnosed in his late 20s and came to our hospital. And then Dr. Bonneman and I ended up diagnosing him, and that's how the foundation started. I have no commercial commitments anywhere. So family planning obviously is very unique and very personal in the setting of genetic diagnosis. So number one is to get a definitive genetic diagnosis, even that report starts with variant of unknown significance. Hopefully, there are ways to then move things from variant of unknown significance into something more definitive, and then that helps you understand the genetic risk. As you know, the RYR1 genetics is a little bit more complex because mutations or pathogenic variants can be dominant, they can be recessive, but they also have, and they can be both, dominant for MH susceptibility, but if paired up with another allele from a partner who is maybe even more silent carrier, then it can act as, more recessive, a double, if both copies of the gene are knocked out or not working. And they can also have, as I hear you discussing, what we call fancily variable expressivity, meaning one person has more involved muscles, one has less involved muscles. And even for the MH phenotype, malignant hyperthermia, what we call decreased penetrance. So it appears to skip a generation, when it in fact is not skipping. It's just sometimes there are other protective mechanisms, or especially if you have more trigger-based phenotype, meaning anesthesia, heat, exertion that we know now is real, and beyond real, that for some people the triggers need to be much more significant than for others. So the spectrum is really broad, which complicates everything. And I think for people who maybe are not as familiar with this, it's professionals, it's just a little harder to understand what, where, and how. So definitely what number one thing is people who have themselves RYR1 myopathy should encourage their presumably unaffected partner spouse to have full RYR1 gene sequencing, but because they could be carrier of, so to speak, truly silent recessive variant or mutation, because a partner's carrier status will affect the recurrence risk, right? So for those who themselves have biallelic or both copies of the gene with a typo, if a partner is not a carrier, all the offspring will be carriers, presumably not then with significant muscle weakness. Depending on which variant, if it's a loss of function, they won't even have malignant hyperthermia risk. Missense variants may still have malignant hyperthermia risk. So it really depends on those variants. In the old days, we used to say all carriers are unaffected. Now we've had our humble pie. And we do know that some carriers are not carriers, but can have especially triggered phenotypes with anesthetics, heat, exertional forces, or also sometimes just very, very mild myopathy, maybe after 30, 40, 50 years of age. So that's where this is so complicated. But if you have both copies of the gene not working, your partner has two working copies, all the kids will have one or the other because there's no other choice. If a partner is also a carrier of something very silent, then the recurrence risks are a little bit different. So that's why we say sequence the partner. Again, if you're recessive, then there's a 50% chance that the child will have both copies of the gene not working, and then certainly there will be a phenotype that again can be variable, but usually childhood onset, early childhood onset, or congenital, or then 50% chance they'll inherit one of the two gene mutations one has, and then it depends on what mutation gets passed on. So testing, I think the take-home message is testing the partner is very important, because I think I just met a family yesterday where it was presumed as MH, it's MH, MH, and I said, I think your mom had the other, and I think you're recessive, So because the prevalence, we don't know what the prevalence is, and the foundation is funding it. But if we look at some of the data, the MH allele prevalence in the general population may be as high as 1 in 6 to 800 people have one copy that has some kind of typo that may be at least at minimum a triggered phenotype. So the prevalence is so important, but it's no longer 1 in 30,000, type of thing. So that is important. So if someone has a dominant variant, right, and sounds like some of you here from just overhearing the conversation, if you have a dominant variant, I would still recommend that your partner be screened for carrier status. Because if you have one non-working copy and your partner doesn't have any typos in the gene, then it's 50-50. But if you have one non-working copy that's manifesting already in a dominant way and your partner maybe has a silent, more classic recessive, then there is still that chance of having, more significant congenital early childhood onset condition in that 25% risk ratio. So my number one recommendation, and if you're here, sounds like you would be open to testing, and genetic testing is something that makes sense to you because it's not for everyone, then getting a partner tested, seemingly unaffected partner tested, should be done. We recommend for anyone, whether you have a dominant or recessive RYR1, as someone who has manifestations. And again, population frequency or prevalence numbers are evolving, but it's not as rare as we used to think it is. Does this make sense? Yeah. That's a real, yeah. 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 So the most important thing is the unaffected partner needs the whole gene sequenced, and what we call copy number assessment, deletion duplication of the entire gene. So sometimes if I have a dominant RYR1 and I want to see if my sister has it, we would just test for that one typo because we are of the same lineage. You don't need the whole gene sequence. The partner presumably is unrelated to you, although all things can happen. The partner shouldn't have just your typo checked or both of your typo checked. The partner should have the whole gene checked, and by dual modalities called sequencing and copy number assessment, because sometimes there's full exons duplicated or deleted, and you cannot tell that by sequencing. Or if they do it in the modern way, something called next generation sequencing that allows for that information to be bioinformatically derived from that technology. So yeah, partners should be sequenced. Or we highly recommend to consider that unaffected partner would be sequenced. So if you have a condition. Just because that recessive and dominant, and nothing is straightforward with RYR1. And again, the major message we used to think is completely benign recessive. And there are people who are completely silent carriers and they don't have any risks. And those are carriers of what are called loss of function alleles. They probably don't have any risk. All right, we have to talk a little bit about, because we live in a real environment, we have to be fiscally and otherwise responsible as adults, so to speak. And there are kind of legal issues and framework. I'm not an attorney or an accountant, but we do like to kind of give the overall view. So one is, what are some of the protections, which is Genetic Information Non-Discrimination Act that was passed during George Bush, second Bush presidency in 2008, which generally prohibits discrimination in health coverage and employment on basis of genetic information. So that's very important. If you want to read more, I have the website link that has really, really good information about it. So you can be discriminated based on the genetic information. And actually, you have lots of protections not to be discriminated against. So GINA prohibits requiring genetic information for decision regarding coverage and prohibits from using it for employment decisions at all, as long as one's duties, job duties can be fulfilled. What GINA did not do, it does not extend to life insurance, disability insurance, or long-term care insurance. That is not protected because those are fiduciary instruments, not health insurance. And employment provisions don't apply to small companies, less than 15 people, military, federal employees, and Indian Health Service. They don't apply to. What was really the huge loophole with GINA was it doesn't prohibit determining eligibility or rates based on manifestation of disease. So again, I've been practicing for 25 years, so there's a person who can have I'm going to use a completely different condition, a gene for breast cancer. They were covered as long as they had the gene but no cancer. The minute they developed cancer, they could be thrown off. But that was because GINA protected, the loophole was, which was huge, is it was manifestation of disease was kind of exclusion. And then it permitted overall rate increase in that. So Affordable Care Act, that we all know lovingly as Obamacare, came in and closed that very important loophole and that was in 2010 because it ended pre-existing condition discrimination on any health insurance policy. So now I think for health insurance, there is pretty decent protection in terms of people fearing getting tested or not. You have GINA that prevents employment discrimination and the basis of health insurance discrimination, and then you have Affordable Care Act that ends kind of additional pre-existing health insurance discrimination. What's still not protected is life insurance, disability, and long-term care insurance. Canada passed life insurance non-discrimination based on genetic diagnosis about 10 years ago. I think it's no comment about any kind of expectation for that to be here. But those are fiduciary instruments, and for people who don't manifest, I generally do recommend getting those policies if that's something you think about in order before you get your test result. Because it's not that your provider will release the test result. If I release a test result, you should call the Pennsylvania Board of Medicine and get me, disbarred, delicensed. But it's about what you write in, right? I never thought about life insurance until I had my own kids, because why do I need life insurance if I don't have kids? And the same for disability and long-term care. But you have to fill out, and it's like your knowledge of then you may need an attorney and accountant to kind of see how to do that. But if you have a condition, it generally should be, or your genetic status, it should be, so to speak, released. But Affordable Care Act was really, really helpful in terms of allowing people to continue to get health insurance throughout their lifetime with a genetic disease. So family planning in the setting of genetic diagnosis is absolutely not one size fits all. It is really individual. We all come from different backgrounds, different kind of foundations of how we think about what's important, how we ground ourselves morally, ethically, religiously. And don't let anyone tell you that there's only one right answer. And there's probably diversity of opinions in this room, and that is okay. That is okay. So my goal today is to walk you through the options, and I'm going to try to do it in as agnostic way as possible, not endorsing any one of them. But it is not one size fits all, and I see the right answers, and my goal is that you find an answer that fits for you and your partner, your family, where that choice is supported by the support system that you rely on. Yeah?
I don't know if it's something you would cover, but my son's de novo.
Yeah. Germline mosaicism.
Can I be covered for that?
No.
Okay.
Why we know, it's a really good question about germline mosaicism. We know it exists from the studies in 1980s, and it was done in families who had 2 children with Down syndrome, right? And Down syndrome is genetic but not hereditary. It just happens, right? It's de novo, meaning the 21st chromosome just happens, non-disjunction, age-related, blah, blah. But why were people having 2 kids? Like, is lightning striking twice? And what I ended up doing is biopsying both ovaries and testes and found that in those who happened again, it was a subset of egg or sperm cells that had that extra chromosome 21, and since then it's been done in a couple other conditions, but we don't do it. Why we don't do it? Because the most likely result is negative, and negative is non-informative. Both testes and ovaries are a collection, it's an organ of billions of cells, and we go in with a needle here, and your mosaic sits someplace else, and you just get a tissue. A negative testicular ovarian biopsy, which is extremely invasive, is uninformative, and the risk of that is so small. You just grab those cells, but not those cells. So we don't do, and we don't recommend, and this is just a negative. The risk of being a germline mosaic is very low. I've certainly met for RYR1 one family, but that it's not, because it's non-informative. Yeah, it's because a negative result means the same as me telling you now. You're still left with 1%, and that's the most likely result. Yeah, that's a really good question. All right, so family planning considerations. Number 1, accepting the genetic risk, knowing it details the recessive dominant, and having children. Perfectly acceptable. Adoption. Certainly we've met families who've chose to go the adoption route. We've also met families, especially 10, 20 years ago, who didn't want to take the risks, but they used egg or sperm donor depending on who has what variation in the gene. And that's called gamete donation, and that's certainly an option. Then there is the old-fashioned way of conceiving, followed by prenatal diagnosis, something called CVS, like the pharmacy, chorionic villus sampling, or amniocentesis, and we'll talk about that. And then there's in vitro fertilization with pre-implantation genetic testing of embryos. That's generally tends to be covered and done with when there is a recessive risk or the dominant risk, depending on what, where, and how. And then kind of what's entered the era of prenatal screening is something called cell-free DNA test, or NIPT, non-invasive prenatal testing. That's been around now probably for 10 years, which is looking at fetal DNA circulating in maternal blood. It's amazing. It's really amazing that the technology can discern that, and they look at for ratios, et cetera. However, it cannot currently be used for single gene variant identification in this, for RYR1. It's only for chromosomal differences. So it's a perfect prenatal tool with, you can see extremely high sensitivities or detection rates for trisomy 21, Down syndrome, trisomy 13, 18, sex chromosome differences. Very good, non-invasive tool. But for RYR1, I called my colleagues actually on Wednesday that work in these companies that do this. They said for RYR1, no. They do have 20 other single genes that they're just added, and that seems to be working well. In the future, they said maybe they can add RYR1, but currently cell-free DNA, even if you know your mutation, cannot be screened in maternal blood, the circulate. This is anywhere starting from like 9 weeks, but that's again not going to be for RYR1. That's for other things. Yeah.
What you're saying is it's not a capability issue. It's a
Technology.
technology issue, or
The-
is it a funding issue to ultimately get?
That's a really good question. I think sometimes you select the 20 genes that they have selected. Natera now has 20 genes selected, and I can open that website a little bit later. It's probably also based on prevalence and the marker development. There are many conditions that are much more common. And also, I'm guessing they also looked at genes that have a little bit more recurrent mutations and not the amazing diversity of mutations we see in RYR1. It's a lot of unique to family mutations. But so cell-free DNA currently cannot detect RYR1 variants. You have to go to the others. So you're left with if biological children is a decision, natural conception followed by prenatal diagnosis or in vitro with embryo testing. So what is chorionic villus sampling? So chorionic villus sampling is looking at the chorionic villi. As you can see, it's outlined there, right? Kind of where there's a placenta and the chorion, and removing that because that's one of the layers that covers part of the what protects the embryo or the fetus, and then it is derived from the conception. Therefore, it's representative, right? You take the chorion, the sac lining, it's derived from the same cells where the conception started with that single so it's that, therefore it's definitely representative of that tissue, of fetal DNA. It is really done based on where the placenta is, because if you look at this, right, it's definitely related to where the placenta is, and the modalities, you wanted someone who does it well, you don't want me to do it. It is transabdominal if the placenta is what we call anterior, kind of more towards the top, and it's done transvaginally if the placenta is what we call posterior in the uterus. So it's really depending on where the placental location is. There is kind of that 1%, 2% miscarriage rate from the procedure itself because it's done in about 11, 12 weeks gestation. In good hands, I think it's probably lower, and if anyone's considering is asking that center their own statistics, because it's very much operator dependent. There are some little caveats that there's maybe a little bit higher. There's something called defined placental mosaicism issues, not for RYR1, but maybe more for chromosomal differences, that those are chromosomal differences limited just to the placenta, not the fetal tissue. But for RYR1, there wouldn't be kind of any ambiguity because placenta is fast dividing. And then there's amniocentesis, which is easier. It's always transabdominal, a needle taking a little bit of fluid that surrounds the fetus, about 2 tablespoons or so. There's fetal cells in the fluid, in the amniotic fluid, right? Because the fetus swallows amniotic fluid, pees it out, circulates. That's what stimulates lung development. And you get the skin cells that have kind of slushed off, and also GI tract because of that. They should be some swallowing. There is definitely some. Yeah, probably. You had poly probably. Yeah, the poly. It's not going as well, but there's some. But there's also, skin cells. Yeah. And and both of those procedures are done under ultrasound guidance. There is much more trivial risk for amniocentesis because the pregnancy is further along. You're just taking a little bit of the fluid that the fetus doesn't miss at all. So kind of the timing, in theory, CVS is 10 to 12 weeks, but most centers do it 11, 12. It really doesn't do it. Someone looked at it again years ago. Can you do it earlier? You really can do it earlier. Amnio is 15 to 18 weeks. Again, most centers will do it right at 16 weeks. The method is, for CVS, is placental dependent, placental anatomy dependent. Amnio is always transabdominal. What's tested is chorionic villi, which are kind of the layer around the placenta. And then in amnio, it's fetal skin or GI tract cells. The chorionic villus, they can do a direct test on the villi themselves. But for single genes, they still need to culture it first to make those cells enough so you can do the genetic test. So that adds, culture takes extra 2 weeks at least to do. And amnio, you always need to culture those cells first before the test can be run. And diagnostic sensitivity is really excellent with both. With CVS, they also automatically run what's called maternal cell contamination test, just to make sure it's representative of the placental DNA and not kind of uterine DNA. Yeah.
So with IVF, we can now specifically test.
Yeah, we're going to cover it. Yeah. Yep. So here's the kind of the miscarriage rates from American College of Obstetrics and Gynecology and CDC for each procedure. As you can see, they're pretty, and I also was able to pull the UK data. And kind of recent meta-analyses, I think on legal paperwork, they still kind of put 1 to 2%. But again, with good operator, you don't want me doing it. And a lot of, also there are less OBGYNs who are skilled in CVS. All MFMs are skilled in amniocentesis, just so much easier to do it. But each center would let you know. So this is natural conception followed by prenatal testing. Couples certainly consider that if the risks are theoretical instead of definitive, like a de novo mutation in a child, and you just really want reassurance. That's often a route that couples take. Because it is covered by insurance then, 100% covered by insurance. Mm-hmm. Yeah, there is a small risk. I didn't include that of early labor but that is also a trivial risk. I don't want to misspeak of that, but it's certainly if there is especially if there is a connective tissue disorder or something that can cause labor, but it's also a very, very small risk. Very small risk. And then we go to the in vitro fertilization with pre-implantation genetic testing, which is something that certainly couples have used, particularly if there's a 50% or the recessive 25% recurrence risk, or right, that's egg and sperm in a dish. I mean, a lot of centers have this, farming terminology. You harvest the eggs and all this, which kind of drives me nuts, but that's what's used. Obtaining sperm is a little easier. Obtaining egg requires, obviously, a medication steroid shot regimen, which itself is not completely without any risks, because when they harvest the eggs, they just don't want to do that one egg you're producing that month. They want to overstimulate the ovaries and hopefully collect 10 eggs, so that that's why one needs that ovarian stimulation medicines. And then there's an embryo, and the testing is done on DNA from a few cells. At that point, and embryos without the pathogenic variant are implanted, generally, kind of the idea. So what's IVF, right? Everyone, I think, is familiar with that. The first successful IVF birth was in 1978 in UK. So the IVF has been around for quite some time. PGT has also been around initially for chromosomal differences, but also slowly for single genes. I would say for a good 20 years now. That is kind of evolving, right? So to looking just a little bit more, so as we alluded to, you need the ovarian stimulation, oocyte or egg cell retrieval is right about day 0. Fertilization is 4 to 6 hours later, and it's either by ICSI, intracytoplasmic sperm injection, if there's any sperm motility issues, or just putting the sperm in the dish. So the embryo culture goes to day 3 of day 5 with a biopsy. And if it's day 5, then there is freezing, which is kind of what's done more frequently. And then it's thawing and next cycle, hormonal cycle implantation. This is kind of more the preferred method I hear from my colleagues, instead of doing day 3 biopsy and immediate transfer. So that is the process, right? So to do pre-implantation genetic testing, one needs an IVF as a methodology. That's the only way, with or without ICSI, and that's something that the fertility specialists determine, and an embryo biopsy. And all the places that do it have an embryologist who does that. Okay, so pre-implantation genetic testing, kind of day 3 biopsy. So embryo biopsy can be performed after 3 days of culture in the laboratory, and that's called the blastomere stage. Embryos are typically 8-cell embryos on day 3, and you can see process involves removal of 1 or 2 cells, and results take 24 to 48 hours, and that allows kind of for, so to speak, fresh transfer. The disadvantage is at this stage, cells are large with significant attachment, and removal of single cell is kind of more traumatic, and they're a little bit lower implantation rates actually. when done at day 3 of biopsy. So most centers have moved to day 5 of biopsy, day 5, 6 of biopsy. And that's called trophodectoderm biopsy. And at this stage, the embryo consists of about 100 cells already. And it is called a blastocyst. And cells are again removed from the very outer layer, called that trophoectoderm. And results, since they still take 24 to 48 hours, the blastocyst has to then be, or the embryo has to be frozen. And when genetic testing results are returned, then the normal blastocysts are thawed and transferred at the subsequent embryo cycle, or the subsequent cycle. So this adds a month of delay for embryo transfer, and additional costs for frozen embryo transfer. But the notable advantage is a biopsy, so to speak, less dramatic for an embryo because it's already at a 100-cell stage or so. Allows for additional chromosome screen, kind of, for just general risks for all of us women have, and higher implantation rates doing it this way.
You're not like, oh, that was this cell that was supposed to be you know?
That's a really good question. So all of these are undifferentiated cells, completely, and that's how the embryo doesn't miss those cells. That's how natural twinning happens. Anywhere in that early stage, you know, between 8 and 100 or so, or 200 cells, just divides in half and sprouts 2 identical twins, right? So the embryo doesn't miss those. Those are completely undifferentiated cells. There's no impact that you're all of a sudden depriving the embryo from proper kidney development. Yes?
When you're talking about doing the DNA testing
Mhm.
of embryos, is that a full screen of DNA or just those like?
Well, no, it's full, the screen is for the specific RYR1 variants, the specific single gene. You can't do exome currently, it's just the technology is not there.
So they can test for the RYR1?
RYR1 plus the chromosomal if you want to, especially if a mom is 35 or older, kind of that all aging egg cell biology risk. Right, but it would be designed, and it has to be planned, obviously. I'm going to talk about it. So pre-implantation genetic testing has kind of undergone its nomenclature change about 2-3 years ago. It's called PGTM for monogenic single gene defects, which is RYR1, PGT-SR for structural chromosomal rearrangement if someone has a translocation or something like that, and then the aneuploidy screen, which is these extra randomly happening trisomies, monosomies, and then, so to speak, combined PGT, right? So there is a maternal age-related chromosomal aneuploidy risk, so it just, our eggs are there, and when we ourselves are 5-month embryos, and they are kind of, the chromosomes are stuck in that dictatine state where they're kind of half divided, and that division finishes only when the egg is ovulated, kind of the full split, the meiotic division. So in a 20-year-old woman, the chromosomes and the egg cells have been in limbo for 20 years, in a 40-year-old for 40 years, and therefore that split in the older egg cell just doesn't happen as well, and is higher likelihood that they'll travel together and give rise to trisomies and monosomies. And you can kind of see the age-related prevalence of trisomy 21 Down syndrome or for any chromosomal abnormality. It's just there is for everyone background, all of us. So maternal age-related risk for chromosomal aneuploidy when done at the biopsy stage, because we do see it, and we do know that probably good half of the natural miscarriages that happen in pregnancies, which is very common, are due to chromosomal abnormalities that just happen. But when you capture, and then those pregnancies, some of those are not even fully registered, you know, by their chemical pregnancies or delayed periods or something like that. But of course, when you have embryos, you can see the more natural rate of those chromosomal differences happening naturally because you're capturing that, obviously, in this kind of in vitro stage, right? So under 35, average number of embryos 5, euploid kind of correct chromosomal complement 62, 37% with some chromosomal difference. So they're kind of always there. It's just the number goes up as one ages, and those egg cells become a little bit older. Because minimum 15-20% of pregnancies naturally conceived are miscarried. Of those miscarriages, half are genetic. We just don't know. We just, we only test that when it's like recurrent genetics, and most of that is spontaneous random genetics, not inherited chromosomal aneuploidies or translocations. So pre-implantation genetic testing for RYR1 requires development of primers for directly detecting the variant and determining which chromosome homolog or pair carries a mutation, and it's done by looking at informative linked markers. So they don't sequence the gene in the prenatal embryo testing. It's just not enough DNA, not capability today to do it. It's done by looking at informative linked markers that surround the gene and the sequences in the gene. And I'll show you that. It requires homolog phasing, which samples from both parents and sometimes even other relatives if it's there. That's why it's quite a big deal to do it. And the family samples are then evaluated for informative markers. And clinical information is referenced to determine which markers around the gene then are associated with mutation and which are not. And pre-implantation genetic testing can be made with combination of a direct variant analysis or what we call homolog phasing, and sometimes homology phasing alone. So embryos that inherit the linked markers are associated with the disease are not then recommended for transfer.
So since we don't have it, pre-implantation is
Yes. I mean, yes. Yeah. You would not be, yeah. Because I think because it's a de novo, I don't think there is testing, because it's not done part of routine testing, to see if the de novo mutation arose on the RYR that came from egg or from sperm.
I'm in a happy situation anyway, so like if you have to get IVF anyway, do that.
Yeah, and I think would need to get also to know on which chromosome it arose, to even get that far, which would then require kind of more additional testing. You can ask them, but usually on clinical testing, when it's de novo, we don't know if it arose on the RYR1 copy that came from the egg or from the sperm. Because for clinical management, it doesn't matter if there's egg or sperm derived, but statistically, it's going to be more likely to be sperm-derived. De novo mutations happen more commonly in the sperm. Chromosomal aneuploidies are more egg-related. So, yeah, it's kind of hard. So if you look at this, here's the mutation, grandfather with the mutation, grandmother doesn't have it, patient with the mutation kind of gets this, and you look at this AATT, it looks AATT, kind of the variants around it. Child with a mutation is AATT. Here's an embryo without, kind of got those T, C, G, G markers so that are tightly linked to that actual thing, and then that would be recommended for transfer. It's not the same sequencing as from your blood or saliva sample. So you need a large number of amplification cycles in order for the pathogenic variant or the genomic sequence around it to be visualized. And this amplification can lead to high risk of regions of DNA failure to amplify or contamination. So here is DNA before amplification, and so to speak, noisy DNA due to allele dropout, which is that ADO abbreviation, after amplification, kind of just 3D visualization. So amplifying the link markers similar to the similar DNA fingerprint close to the pathogenic variant of interest is absolutely critical. So it's uniquely designed markers for each mutation, variant, and because there's variation in your RYR, normal variation, your RYR sequences based on your unique kind of genetic background. So here is kind of what allele dropout looks like. So amplification of only one of two alleles present in a heterozygous single cell. Here's the disease mutation. Here's amplified DNA limited kind of markers, the allele dropout that you see there. Here are the linked markers, right, that are kind of there. And here is, you only get informative marker 1. You don't know because there's allele dropout. By amplifying, it's just a technical limitation from this. But the more markers you have, the less this allele dropout, the natural technical limitation, impacts the outcome. So that's why preparing and planning for it and finding those markers for the lab is critically important. Because if you only have 2, it may not work as well. If you have 10, it's going to work really well, if that makes sense, right? So evaluating the numerous markers surrounding the disease gene is important to avoid misdiagnosis of embryos. And just to kind of give an example, this couple has had a child with some completely different condition called SMA, spinal muscular atrophy, that currently has gene therapy. I met them 20 years ago. They had their first child, whom they lost to SMA. It was certainly one of the common lethal conditions. And they decided to go with IVF with pre-implantation genetic testing, different gene, different kind of testing modalities, but still recessive. But just to illustrate the point, there were 10 eggs retrieved after ovarian stimulation. 6 embryos made it to the stage where they could biopsy them. 4 embryos had informative genetic test result. Yes, this is a few years ago. 2 were unaffected, 2 were affected. The 2 unaffected embryos were transferred, and there was a singleton pregnancy. The point I'm showing this, there's drop at every step. It's just how it is. And even though technology is better, there's still drop at every step. Just because there are 15 eggs retrieved, it doesn't mean there's going to be 15 embryos. They live to tell that story in Good Housekeeping, kind of their success. And they're wonderful, and Harrison's now in college. I love getting the Christmas cards. But it is, sometimes the reproductive fertility centers make it sound a little bit easier, and sometimes those kind of farming nomenclature terminology also makes it sound like, oh, you just retrieve, you harvest, you implant, We're dealing with humans, and it's not always as easy. So related risks, right, the fertility medication-related risks, the procedure-related risks associated with egg retrieval, those are something that the OBGYNs, fertility specialists, should be able to answer. What is your specific risk factors? Because gynecological factors come into play, and I have no business commenting on that. Risk of multiple pregnancies, associated complications, right? These days, typically no one implants more than 2 embryos. Remember the Octomom story a few years ago? There's slightly increased risk of imprinting disorders or epigenetic changes if there's IVF with ICSI, intracytoplasmic sperm injection. So there's no DNA sequence change, but the prevalence is slightly higher for genetic conditions that arise from improper gene expression, something called Beckwith-Wiedemann syndrome, Russell-Silver syndrome, kind of other. There's very small number of genes that are differentially expressed, whether they come from egg or sperm. We know there's some kind of hotspots on chromosome 15, 11, 7, that there are genes that are differentially expressed. Most genes, 99% of genes, are not subject to imprinting, meaning only expressed if they come from egg, only expressed if they come from sperm. Most genes are equal expression regardless if you get it from maternal or paternal origin. And obviously, no guarantee that a birth will occur. There is a miscarriage rate. PGD, pre-implantation genetic diagnostic testing, is not viewed as 100% sensitive, and prenatal diagnosis is routinely recommended as well. It's rare, but in theory possible they'll transplant the wrong embryo that they labeled. It is possible. In terms of timeline, so referral received. About 1 week later, there's genetic counseling phone session. Another week later, genetic team reviews the case. Another week later, there's genetic counseling phone session. Then there's DNA collection kits sent so they can develop those markers around the specific mutation that is there. then all DNA samples received by lab, depending how quickly you swab yourself and on the FedEx strike or not strike day. And then it takes about 2 months then to develop, for the lab to develop. So you're looking at 4 months usually, to even get the lab to develop that. And patients that are not instructed to begin their IVF cycle until PGT development process is underway, until it's completed. So it does take some lead time. So obviously what to consider is also emotional and financial decisions regarding number of cycles to pursue, understanding the risk of having an affected child and clinical implications. What if all embryos are affected? Would you still consider transferring a carrier, which we currently know may have only MH, I put in quotes, but may not have congenital myopathy, but may have MH and maybe muscle condition, in 50s and 60s. Will IVF clinic let you transfer a carrier, so to speak? Will they, definitely seen couples that then decide, well, we'll transfer affected because that's all we have. And then one should find out or participate in discussion what happens of embryos that are not transferred. Is it, disposition, cryopreservation, embryo donation to other couples, or to research for those, especially if they're affected embryos? Not federally funded, but non-federally funded. Yeah, federally funded is, more challenging. Yeah, there's no new kind of embryonic cell lines can be established on federally funded, but that has to do with federal funding versus private foundation funding. Yeah. So costs, it's not cheap. The IVF cycle is anywhere from 12 to 17,000. Frozen embryo transfer cycle is 3 to 5, and the PGT is about 3,000. I'm probably going up. This is a little bit a year or two outdated numbers. You have to investigate your insurance coverage. Some plans have lifetime benefits for any assisted reproductive technology, like you have $20,000 and that's use it how you want. Some plans cover IVF, but not the test. Some covers do the opposite, don't cover IVF unless you're infertile, but will cover the test, and IVF is the more costly part. You need letters of medical necessity, and obviously clinicians who are willing to appeal with you multiple times. I've been successful in appealing, and I've failed in appeals, kind of both ways. And working with your employer's HR personnel, because it's not Aetna that's not willing to pay, or Blue Cross. It's the Verizon you work for, or whatever, Penn State you work for, that underwrites what Aetna should cover, right? And if they say make an exception and cover, we'll give you a little bit more money, that's possible. All right. Questions? Yes.
I know you can't recommend a lab recommendation, but is there specialization in the identification portion of this, i.e., we talk about this uniformly, like you're just going to go to the IVF station in your own town, or the closest thing to you, right?
Yeah.
Is there enough specialization in certain areas that there's differentiation between,
Understood. Yeah. So I think I'll answer. I'm just pulling up my friend here. So Natera used to do it, and I had a bunch of CHOP people who work there, so I used to refer to Natera. They no longer do single, custom design PGT, and they say now the good companies are Luminary, Revity, Cooper, but you can still go to the larger reputable center that that does IVF and has a staff embryologist.
Yeah.
That's what you look for, staff embryologist. But everyone's samples, embryos, get FedExed. No one does the testing on site. It's done in like 3-4 labs in the country that do it. So you need a good staff embryologist that's used to doing it, does it a couple times a week. But it will always be shipped to the lab, because the lab that will develop those markers is not going to be at the site.
but there's like the science is the effect of the lab is agnostic as to
That's really good. Like Natera, when they used to do it, I know they've done for several families in this community because I kind of help handhold them to that process, but they stopped doing it. So you can ask if they've developed primers for that gene. Those are good questions to ask. But I think the most important thing is they're willing to do it. Yeah. You can ask if they've had the lab that the fertility clinic uses, the lab they work with, have they developed for RYR1 specifically in the past? Yes, but everyone's embryos get shipped. And then they just get these days, obviously, email note back, like embryo 1, 2, affected, unaffected, and it's the local site labeling and, all this is, you're dependent on your local clinic, yeah. Great questions.